colleagues formed Green Springs Health Services, Inc., now the nation's largest behavioral health care company, Magellan. During his tenure as a corporate officer with responsibilities successively for product development for the Blue Cross Blue Shield market, for sales and marketing, and for governmental services, he grew company revenues from $3 million in 1990 to $200 million in 1995. Prior to entering the private sector, Bill served in management and executive positions in the federal government. Bill has many publications and is a speaker at professional and trade organization conferences. Welcome both Patrick and Bill.
Well, thank you very much. I'm Patrick of the Patrick and Bill Show. And I want to thank you all for inviting us. It's an honor. It really, truly is. I think I'm speaking for both Bill and I, that this really is an honor. We feel very strongly about our relationship with the Resource Center. And I know that the work that we've been doing now for the last, 6 months or so with you is all in this vein of, making sure that we optimize and maximize the opportunity. And, in Paul's opening remarks, he touched on what I sense when I go around the country and talk to people in the field, weekly, it seems, in another part of the country, talking to folks who are feeling that uncertainty. And I think that really is the sort of baseline feeling sense that we all have. And it's more than a feeling sense, it's really an intellectual sort of condition that we're all in. It says, well, we think that this is what's happening, but we're not really sure. And if that's the way you feel, everybody feels that way at every level. And the volatility that comes with that, and the complexity that accompanies an undertaking the size and the nature and the scope of healthcare reform is unprecedented. We've never been through this kind of change. So if it feels, I think Paul's word was ominous, it's because it's ominous, it's big. And we're just sort of getting our hands around the contours of it and all of the various characteristics. And I think that at the end of the day, we have a choice, essentially, and that is we can sort of back away from it. And there are some people who are taking an early retirement in the face of healthcare reform. We're backing away. And there are others who are saying, you know what, complexity, volatility, and uncertainty are the garden of opportunity. That's where you get to plant seeds that are really going to grow, that are really going to have an impact, that are really going to produce positive outcomes and results for individuals that you're serving, for the employees that you're nurturing, and for the business that you're growing. So, and that's really, I think, the feeling sense that we want to promote today is look at this as an opportunity. The more unsettled things are, the more uncertain they are, the greater the risk, but the greater the opportunity. And so why look at it as a risk when you can flip it around and look at it as an opportunity? And I think that it's good for our mental well-being, our own spiritual fitness, our own careers if we look at it as an opportunity. And frankly, if you look around the country and you read the headlines, there are a lot of people around the country who are betting big on healthcare reform. And they're moving forward. And they're doing it with courage, and they're doing it with whatever motivation they have. But I think that if there's that many people moving forward, well, we may as well move forward and see it as an opportunity. In the process today, we're going to go through this very quickly. And I told Bill, so we'll just kind of set the stage. We're going to fly through our slides. You have our slides. That material is there to read, to study, to do your research, and let it raise questions. And hopefully, at the end of our pitch, you can ask questions, and we can have a conversation that will continue tomorrow. That conversation. But we will go quickly, and to take an hour to provide you an overview of something like healthcare reform is ambitious, what we're more interested in are what are the implications for the community you serve, for the very special populations you serve, And what are the implications for you as the Resource Center and as people who go to work every day and have to make sense of the opportunity and take advantage of the opportunity? So we want to talk about those implications. And before I pass the baton to Bill to take us through the overview, you know, Paul, you used the term digital age in your opening salvo. And I was telling Bill at dinner last night, I said, this is the integration age. You know, we've had the Industrial Revolution, and we went through the information age and the digital age, and I think that this is an age of integration. But I want to plant a seed beginning now that it's more than the integration of primary care and behavioral health care. That I think is superficial. I think that we have an opportunity, if we kind of open our minds to it and open our hearts to it, to integrate and to evolve. You use the term evolution, both as individuals and as a system of care where we can really begin to provide people the opportunity for a wholly integrated experience where we take care of that whole person, but we're not doing it at the exclusion of others in the community. And I think that that's been our problem. In our field, we've understood holism for decades, and we strive every day to provide that holistic experience, but it's like we're having to do it in spite of what policymakers and what payers are wanting to do. And I think that that's the difference today, is that policymakers and payers and providers and the populations we serve are all sort of colliding and becoming one. And that's, if you understand anything about these accountable care organizations and so forth, we're going to see these hybrid models where it's going to be difficult to distinguish members of the board who's the payer, who's the policymaker, who's the consumer, who's the family member. We're all, I think, going to be integrated into one unit, which is exciting. It releases and relieves the tension that we've lived with as payers and providers for a long time. So with that, Bill, do you want to take us through an overview, and then we'll start to dig in?
It did say, I might have as well, thank you. It is a pleasure and an honor to be here with you today. Our focus will be on the Affordable Care Act. As Patrick said, we're going to try to fly through it as fast as possible. And we're going to focus on 4 key provisions and some of the resulting implementation issues that come from this. First, let me just take a real quick cut at the Affordable Care Act and the 3 basic rationale for the Act. One is access, of course, and too many people in this country without coverage. It was 35 to 40 million uninsured Americans that triggered the Affordable Care Act. The ACA and the fact that people either don't want, that's a small number, and they tend to be young, can't afford, or wealthy, and can't obtain. One of the things that the Affordable Care Act did is create what's called, they deny, you can't deny for pre-existing conditions anymore. And I'll touch a little more on that later. Quality is the other major indicator. The United States lags terribly on many measures of population health. If you look around the world at what other countries are doing, I think one of our we score about number 18 among the major Western industrialized societies in terms of overall measures of population health. And then cost, of course, is a big issue as well. Half a decade of continuous cost increases now. It's 50 years of cost increases in our healthcare budgets, approaching 18% of GDP, and it's more than double most Western democracies. In terms of basics, it was passed in 2010, and it really contains 10 titles. I just listed the first 4 here. They touch on the Social Security Act, which is the most fundamental structure of our whole health and social service system in the country. It's 1 titles now, the Social Security Act and the Affordable Care Act, and its 10 titles impacted in some way almost every one of those other titles. In terms of the major overall changes, just hitting them briefly, it's now universal health care, of course, benefits for all Americans, although we'll touch on the Supreme Court decision in a minute, how that affected things, but as enacted, it was to provide benefits for all Americans, and that was 32 million newly covered lives. There's no denial, as I mentioned, for pre-existing conditions, and for adults that comes into effect in 2014, and for children above age 19, it's in effect today and was after enactment immediately. There are no lifetime caps on coverage anymore, so if you had health insurance, you could have a very serious accident, blow through your lifetime cap on coverage and be uncovered. And 20,000 people a year hit that limit before that act was passed. And finally, or not finally, insurance administrative costs must remain below 20% of premium. I have 80% there. That's the premium amount that has to be spent on health care. 20% administrative cost is rather high. I think the federal government operates its health care programs on something like 5% administrative costs. So there's one of the real issues in health care today. And of course, under the Act, more preventive care, now free of charge, is being provided. And children, of course, the most popular one, I think, and part of the politics that caused the Supreme Court not to suggest that they would make a political decision, but in some sense, they're ultimately a very political organization in terms of interpreting our laws. And this particular provision, I think, was one of the items that caused the Supreme Court to come out the way they did. And that's the coverage of parents or children on their parents' policy until age 26. I'll just very briefly hit the 4 key provisions that we're going to talk about today. We're going to talk about access, coverage expansions, and constitutionality. We're going to talk about the new program models, particularly ACOs and dual eligible initiatives. We're going to talk about new administrative structures and framework that's provided by them in terms of the essential health benefits, one of the key concepts that particularly advocates need to keep in mind. And then one of the key new implementing features, which is the health insurance exchanges. We'll also talk about new financing mechanisms, the linkage of performance and quality. And just very briefly, we'll note the federal parity law and the impact that that has. Sure. We'll go ahead and do the coverage expansion very briefly. 2 basic coverage expansions. One is the Medicaid expansion to childless adults. And the other is the state health exchanges, and they both target different populations. Can you hear me okay if I don't speak too close to the mic? I'm trying to get that feedback loop. Touching on the Medicaid expansion to childless adults, one of the key features there is that it's for the essential health benefits, and that includes mental health and substance abuse services at parity level for all benchmark plans. These are the plans that states will elect. New York State will elect his. Each of 50 states will elect their own benchmark plans under the Medicaid program for the essential health benefits that they provide. And the feds will pay 100% for 3 years, of course, under the Medicaid expansion, and then it drops down after 3 years to 90% coverage. So those states that elect not to get involved, of course, this is the current political debate, how many states will elect to participate and those who won't. New York is definitely one who has already elected to provide coverage under the expansion and is moving ahead very aggressively, in fact leading the country in many respects. The Medicaid expansion provides for a simplified enrollment process, and there are even going to be web apps to get coverage, and we'll say some more important things about that in a minute, in several minutes. The data will be integrated within state health exchanges, so people who are on Medicaid today will get their coverage through an exchange. It's in place in Massachusetts under their health exchange program, where there's virtually universal coverage, and of course it will cover foster children up to age 26. Under the state exchanges, another very important part of the Affordable Care Act for those who are working, covering 133% to 400% of the federal poverty level, which provides coverage for essential benefits at the parity level without co-pays for prevention, and many of the services will help individuals and small employers who are purchasing group health insurance. There really is a market, a new kind of market for small group plans in the individual market, which are big parts of the health insurance structure in terms of the markets that are covered today under commercial health insurance. There will be, of course, differing levels of benefits that one can buy, and there will be vouchers to pay premiums and provide cost sharing from the employers who participate, make this available to their employees. And there will be this effort to make healthcare understandable and affordable. I just see a show of hands. Anybody who has a health insurance benefit that feels they fully understand that benefit. So the idea is to make this information about health insurance and providers transparent, so that consumers can ultimately understand what is it that they're actually buying with their premium, and what information about providers, but information about the insurance itself. And exchanges are going to, we'll touch on this in a bit, are going to have people called, I want to say explorers. Navigators, thank you. It will be an exploration, believe me, but navigators to help people understand their health insurance and purchase it. And there will be opportunities for organizations to help do that for people with special needs. So it's very important to think about the health exchange as a vehicle for participation on your part collectively as a provider that's interested on those with people who have special needs and are handicapped. And then again, there'll be one application, so in an effort to destigmatize health insurance in terms of, it's not welfare that people are on, that you're getting health insurance. That's very quick points about the two types of expansion. The constitutionality, the Supreme Court of the U.S. resolved that constitutionality issue, as you know, as you're aware, an individual mandate remains, but Medicaid expansion is allowable but not enforceable through elimination of all funding, and that was the key issue for the court. As a result, even though we don't know what the outcome is going to be until 2014 comes and states have finally elected how they will provide their coverage, but the best estimates that are available today through the Congressional Budget Office now suggest that instead of $13 million that they projected would be covered under the exchanges, under essential health benefits, it's now down to $7 million. And of course, there'll be no impact in New York because they're going to go ahead with the exchange. This is the national number, and New York's projections for its expansion population remains. And one big issue in Maine now and several other states where governors are saying we're going to cut our Medicaid expenditures because we're having such a budget crisis in our state. That there's been a recent interpretation, at least by the Congressional Research Service, that says this cannot happen. So there are some big politics and fireworks that you're going to be watching happen nationally in certain states that say they don't want to proceed with expansion. And this is just a quick snapshot that was done last week by Modern Healthcare on plans to expand the states that will expand, and they talked to all the states, and only 26 responded. They went to the governor's office. New York's not included in terms of plans to expand, but California, which is the largest Medicaid program in the country, said yes. And one of the smallest, Rhode Island, also said yes. This is just a status report as of then. And I just want to emphasize that New York is going to lead on the expansion and on health exchanges, and already does. In terms of other coverage effects, one of the real tensions is going to be between the federal exchanges and the Medicaid expansion. The exchanges are going to operate in every state. That was not affected by the Supreme Court decision. So these new markets for health insurance will exist, and if states elect not to develop them, which many states are dragging their feet, there's a long 3-year implementation process. You have to pass a basic law, you have to set up an operating board structure, many requirements. Not many of the states are through. In fact, there are, I think, about 13 today that are already set up to operate their exchanges. And so there'll be some conflict between those states that say, we don't want to operate an exchange, in which case the feds will set up an exchange. So in every state there will be exchanges. Some will be state operated and governed, others will be federally operated and governed. So that will certainly cause some conflict. A couple of the other key points, I think, newly eligible people under Medicaid, approximately 1.7 million are likely to need mental health and services. They'll account for about 13% of the Medicaid dollars, and they will be provided coverage. One of the other issues is going to be this, and you're going to experience it here in New York as well, unless something is done to adjust it, is that people will churn between the essential benefits and the exchange plan. So if you have a job, you're getting a subsidy from your employer to buy your insurance, you're not paying any money out of pocket, you're on Medicaid, you have a program that you're signed up for. If you're working and then lose that job and have to be provided coverage under the Medicaid expansion plans, there will be a shift in eligibility, and that's going to cause some problems. It's going to be difficult, and I think people recognize it and are going to try to address it. But it's one thing that you'll experience for your population is that you want to make that transition back and forth as seamless as possible. And as advocates, you want to make sure that your state recognizes that problem and addresses it. Next, let's talk about the key models under the exchange, under the Affordable Care Act.
Good, thanks, Bill. Yeah, I think the impact of these two major expansions in coverage is the creation of a new market structure. It's Bill alluded to the essential health benefits, the benchmark plans that will underlie both Medicaid expansion and the health insurance exchange. And suffice it to say that as those coverages change and the benefits change for each of them, happening simultaneously, we've got Medicare leading the charge of creating accountable care organizations, and accountable care organizations, just to sort of encapsulate this with the time that we have, are really an effort to address population health needs. So I think they're very important to the Resource Center because you are serving a well-defined population for the most part with special needs and with chronic condition needs, which is another hallmark of accountable care. The second hallmark of accountable care is that it brings together in a way that we've not seen before the provider and the payer, and puts them under one roof, and in a very sort of primary care centric fashion holds both parties accountable for achieving the triple aim. And the triple aim is for our healthcare system is going to be about, of course, producing better outcomes, better quality. I know Bill talked about our lagging quality in this country, a better patient experience, a better experience for the provider, but at the same time, we've got to control costs. And that's got to be, I think, something that as providers, especially in the fields that we're in that we develop some comfort around. I mean, this is one of the implications for us, is to be able to talk in terms of producing savings. And, you know, I was a provider in the 80s, and then in the 90s I was a managed care executive, and it was like talking about saving money was the purview of the payer. And the provider, it was almost like providers weren't allowed to talk about saving money, because saving money was about disqualifying people for treatment. It was about turning people away. And that's not true anymore. I think with the accountable care organizations, you're going to see a blueprint for providing care that reduces unnecessary care, in many instances unsafe care, and making sure that we provide the very best and most effective care at the right time, at the right place, at the right level. And I think in the long run, if we can reduce unnecessary admissions to hospitals, if we can reduce the use of unnecessary prescription medications, and reduce the use of duplicate tests and labs and duplicate imaging, those are the kinds of cost savings that in the long run will make the whole system of care more sustainable for everybody. The other significant market structure that Bill's going to talk about, so I won't go into it in too much detail at all, is the dual eligible initiatives and waivers. You know, around the country, everybody recognizes that the dually eligible, those that are eligible for Medicaid and Medicare, simultaneously represent a significant challenge and significant cost to the entire system. So how do we develop a system of care, a delivery system that does a better job for those folks that are dually eligible? And then the other market structure that I would imagine you're starting to hear about or you've delved into are these health homes and patient-centered medical home models. And in many respects, they're a clinical blueprint that, frankly, I think we're going to see replicated in accountable care organizations. They'll be the sort of the clinical model to the business model of accountable care. And the truth is, they're not new. They've been around, the idea of a patient-centered medical home or a health home for decades. Pediatricians started pitching the medical home model 40, 50 years ago. The idea being that there be a hub, in the case of primary care, where primary care is the hub, and there's medical case management happening there, where I think too, in many cases, the navigation will happen too, through a system that is really arrayed as spokes around the hub, so that someone can come in one door into their primary care home and be referred and monitored and managed through a whole array of services where there's continuity, communication, cooperation, and in a very formalized way. So we've talked about having that level of communication and collaboration for years. We've wanted it. And what these health home and patient-centered medical home models do is they really formalize it, standardize it. As a matter of fact, health homes and medical homes will be accredited, and they'll have to demonstrate that they can accommodate, they can facilitate all of that communication. And I think communication is really the key. If you think about this idea that I come into a home, I get referred, I get tracked and monitored, that aside from the willingness of people to make those referrals and to the activity of picking up the phone and so forth, the thing that underlies, that makes that most possible, is the exchange of information. And in the past, the not too distant past, we weren't able to exchange information. There wasn't a mechanism for it. You'd have to, get the chart, and we'd try to fax things, and of course HIPAA came along, and we had to try to reconcile the exchange of health information with HIPAA. And but today, with electronic health records and health information exchange and the meaningful use of health information, we're going to finally be able to accommodate these models in a way where in real time, one physician can be looking at another physician's notes, the lab results can be dropped right into the medical record in the hospital, the primary care physician can see the imaging, all of that can be happening in near real time or real time. All right, let's dig in a little bit to accountable care organizations, and I'm just going to kind of blast through this, folks, because we're going to have to. I think the thing about an accountable care organization, if you keep in mind this idea of a health home, because I think it's a good mental image of there being a hub with spokes, the accountable care organization throws a wrapper or a membrane around all of those and says we are an integrated delivery system. So we come into that system as providers, whether we're the hub or we're the spoke, in a very deliberate way. We're partnering, it's a joint venture, and we're creating a new organization in the process. We don't stop being an autonomous organization, so in your case you would remain the resource center, and nothing would change with respect to your being the resource center, but when you become part of an ACO or an accountable care organization, it is a new business entity that's created, and that new business entity has its stakeholders, it's got its members, and it has to be able to share monies back and forth within that membrane. Okay, so it's a joint venture. There are contracts, and people have an ownership stake in it. There were 32 pioneer ACOs that CMS launched, what was that, about 6 to 9 months ago? Yeah. And then just about 2 weeks ago, CMS announced 89 new ACO entities. So you can do the math. Those are the CMS formally announced ACOs around the country. We're now well over 100. And the last estimates I saw, there are 200 or 300 more ACOs that are in various stages of inception and development, okay? And they become accountable for all of the care provided to Medicare beneficiaries, okay? So ACOs specifically designated for Medicare purposes. They are providing and conducting the services associated with both being the payer and the provider. Okay? If you're familiar with the Kaiser organization and Kaiser plans, that's really been the hallmark of Kaiser, is that they're both the payer and the provider. That's the nature of an ACO, of being both. They have to promote evidence-based medicine and engagement in care, and they have to report standardized quality measures up to CMS on a regular basis. They must invest continually in the workforce. Okay, and all of their what's called shared savings, all of the finances are tied directly to quality and outcomes. So unlike managed care 1.0, the managed care you and I were involved with decades ago, this form of managed care says there are no goodies. Okay, as the entity, as the ACO, you don't get any incentives or rewards until you make people well. Okay? That's a very different equation than the one we've been living with and that we struggled with in the 80s and 90s, where if you withheld care, you made more money as a managed care organization. So now you've got to provide the right kind of care at the right place, at the right time, for the right reasons. And if you produce a positive outcome and quality of life improves, then you get to share in the savings with CMS. Okay? Oops, let me go back. What are the types of organizations? Again, they will have a formal legal structure to receive and distribute monies. They'll have sufficient number of primary care professionals. These are very primary care centric. They're about making sure that we build that medical home or that health home in a way where a sufficient number of primary care providers will meet the needs of a defined population. And as they form that legal structure, they have to contract with CMS for no fewer than 3 years. They have to have an organizational structure and management teams. As I said, they've got to report data. They have to promote evidence-based practices. And they've got to, of course, coordinate care in a patient-centered way, as defined by the Secretary of Health and Human Services. How do they qualify for savings? On an actuarial basis, They look back, CMS will, and say this population, let's say it's 10,000 people, spent X number of dollars last year on all of their health care, every stick of health care they consume. Okay? So they will get that sum, X number of dollars, all right, for that defined population, and that becomes the benchmark. That's what they're trying to come in under. All right, so for X number of people, let's say it's $100 million. Well, the object is provide better care, produce better outcomes for less than $100 million. And then on a quarterly basis or an annualized basis, depending on how they set things up with CMS, then they'll come back and reconcile and they will share savings, assuming the quality and the outcomes are there. All right? When did this begin? It began, notice the past tense, January 1st, 2012. And again, we've got these 32 pioneer plans around the country, and 89 more plans were announced just a couple of weeks ago. The NCQA, as I said, will be accrediting and certifying these bodies, these ACOs. I'll let you read the details, but they've got to demonstrate that they've got the program structure in place with all of the right components, that they've got adequate primary care representation, that they can provide access and availability, all right, including some of the times that are a little unconventional in terms of making sure people can reach after hours and on weekends. The care management be in place to assess people's needs and to point them in the right direction at the right time to the right kinds of resources. That there be seamless transitions in care and not the kinds of transitions that leave people scratching their heads and wondering, you know, where do we take our son next? That patients have rights and responsibilities and that they're aware of them, and that the performance reporting is robust, timely, and valid. Okay? That there be clinical pathways, that there be the care coordination and navigation, that the medical or health home care model is in place, and that there is a preference for, they tried to mandate it, but they had to walk back from mandating EHR or electronic health records. Now there's a preference. They're going to recognize, there'll be a special recognition for those ACOs that are already able to share health information appropriately and electronically. One of the things I want to point out on this screen here is the clinical pathways and how important those clinical pathways are in the instance of special needs populations. You guys understand evidence-based practices and clinical pathways for your populations better than anyone. And I think that that's one of those things when you think about what makes us different, what makes us attractive, what makes this an opportunity for us is that you understand the population you serve, you understand their needs. There are hospitals and there are clinics and there are surgical centers all over the place, but they don't understand your population the way you do. And I think that that's, you know, we were talking about that at breakfast. It's going to be real important for us to keep that up. This is our piece of the pie that we understand that we do so well, that we've been doing for decades, and we need to bring that to bear, bring that to the table. Some of the obstacles, it's going to be a very expensive startup. There are people who think that this is going to be an era of monopolies and conglomerates, and yes, it will be. It's already happening. The rate of acquisitions and mergers and consolidation across the healthcare spectrum is not only has it begun, and it's quickening. And every day we're seeing all kinds of mergers and acquisitions, and those kinds of opportunities are for some people very good. Others might say, you know what, we really want to remain autonomous, and what we'd rather do is some kind of a joint venture. But all of that affiliation, alliance building is happening, and it's going to continue to happen. Some of the other obstacles include having to figure out how much risk, financial risk, we can absorb as we move forward. I think as we talk about the essential health benefits in a little bit, that one of the risks is, are the right kinds of benefits there for the right kinds of services? And that's going to be a real question as to what makes a health benefit essential, and is what's essential to one group of consumers equal to what's essential to another group. So are the needs of the elderly the same as the needs of a pregnant woman? Are they the same as the needs of an IDD population? So we've got all kinds of different groups, and how do we reconcile that in what's called the essential health benefits? So I think that that's going to be one of the risks. Now let's talk about dual eligibles, and I'll pass it back to Bill to take us through that.
We're going to hear more about this from some of your other speakers, so I'm not going to dwell too much on it, but just to frame it briefly, Medicaid and Medicare are very complex programs. Many people have both benefits, and so the goal is to try to provide seamless access to high-quality care delivered cost-effectively. That's the stated goal for these dual eligible demonstrations. It's intended to bring together all medical, behavioral, and long-term services and supports needed by people who have dual eligible. So that's a comprehensive package of services, not as fully comprehensive as you deliver today, because you're talking about employment and other kinds of issues, housing issues, employment. There's a range of issues outside the broader definition of health care that's being proposed under the Affordable Care Act, that is in place under the Affordable Care Act. But it's not as broad as the set of needs you cover. So this is a very important demarcation point, particularly when it comes to rate setting and operations, and making sure that other parties at the table continue to make the appropriate and necessary contributions they have to make. So the social safety net under the Affordable Care Act covers health. It's a much broader definition of health than we're used to in our field, but it doesn't include everything. So some rationale and assumptions for the act you've heard before. I'm sure I won't go into the details. Just touch on two. Medicare represents 21% of the population of people who are dual eligible with 35% of the funding, and Medicaid represents 15% of the population with 39% of the spending. I'm sorry, that's broader health all told. There are many operating conflicts. One of the reasons to try to coordinate it or integrate it, as Patrick was saying, is that there are these operating conflicts. There's cost shifting that goes on very often. If you want to read, go to the Medicaid Director Letter. It's on the CMS website for July 8, 2011, where the program is launched and definitions are set out federally for how this is to be done. So far, 15 states have received additional $1 million award, design awards. New York was among them, and the initial letter of intent due from the states to participate in the demonstrations was October 1. This is CMS's case for dual eligibles, for integrated care. Right now, there are 3 different ID cards a person gets if they're dual eligible. Under Medicare, they get their Medicare A and B, their prescription drug card, and a Medicaid card, all of which have unique and special benefits. Under integrated care, they argue with one ID card, it would be simpler for providers to manage the complexity. You all know anybody who does billing, those people with incredibly strong constitutions knows how difficult it is to provide, make sure you get reimbursed for your services by virtue of the 15, 20, 25, 30, 40 insurers that may come through, patients who come through your door with those 35 or 40 types of health insurance plans. So very important that this idea of one ID card, the simplified process, can be very meaningful in terms of administrative costs. Anyway, there are 3 different sets of benefits. Under integrated care, under the dual eligible demonstration, it's one comprehensive set of benefits that includes primary, acute prescription drugs and long-term care. The present structure often finds multiple providers that don't coordinate their care simply because they it's never been expected of them to coordinate to the degree that it will be under this program. And of course, the case they make is that a single coordinated care team with a comprehensive care plan can do this much more effectively, and that's undergirds so much of what's going on. The healthcare decisions, you have multiple parties making decisions, and people are not talking. So you're going to get different, you're going to get conflicting policies, and not very effective care as a result, of more limited in terms of its effectiveness. And then under the present structure, they argue that there's a lot of incentive for it's easier for people to go into nursing homes, but with non-traditional benefits, people will be able to remain at home. The demonstration requirements are listed here. They're lengthy. New York State has its waiver, 150 waiver, and program out there in the public record. It's important to review. These are some of the key features in it that they met by virtue of writing the plan and getting it approved, and requires all these things. If I go into them, we're never going to get through, so move past them. And then New York's approach, of course, was its people first waiver, focused on community long-term care services and pilot projects beginning in 2013, and it would have been partially capitated long-term care initially, with potentially fully capitated health care, incorporating the whole healthcare spectrum, including inpatient, hospital, RPCs, etc. And then this is their set of intents. Members will be enrolled voluntarily, so there would not be mandatory enrollment, the outside evaluation. Of course, this is all changing, and so you need to very much stay abreast of it. I know you are. You need to stay very close to your state representatives. I'm glad there are others that are going to speak to some of these issues. Again, that it will require that individuals have self-direction and an individual service plan budget. It will require many of the things that you're used to doing, but in some new ways, and it is a real opportunity, notwithstanding the risks that are there. We will touch on some of those. Of course, the Resource Center hasn't wasted any time here, and they went ahead and developed a readiness proposal that emphasized a number of key points about the organization in terms of its capacity to deliver a fully integrated program. Key points: strong history, its integration in the community, the diversity and evolution of current organizational capability. You could read the points. I don't need to read them to you. It was a very strong proposal. It enabled PRC to begin a conversation with the state and continue a conversation that's been going on, well-informed, however. Of course, the implementation challenges are the lengthy and complicated procurement process that the state government will go through, very fluid policy and political environment, the federal election of the president coming up there. Certainly, whatever happens, certain things are going to go forward. The Affordable Care Act is law. It has to go forward. And what kind of revisions should the other party come into power, the Republican Party, the extent to which that will change. The Affordable Care Act is all dependent on what any new legislation would be. So the other key challenge is sort of the risk of being a leader first out of the gate. Just touching very briefly on the administrative structures that are created under the Affordable Care Act. We'll touch on two: health exchange and essential health benefits. We mentioned them. Some of the exchange basics are mentioned that it's the individual and small group markets that are going to be affected by exchanges on the commercial side, and already gone over the requirements, income requirements, and the argument for it is, of course, to facilitate health plan competition based on price and quality, the ability of consumers to understand and make intelligent choices based on their needs, the use of navigators to assist those with unique needs to make a full assessment of what plan is best for them. The current status on health exchanges as of the Commonwealth Fund's most recent report is 13 states have enacted laws, and recently HHS said your act would accredit what are called the qualified health plans that have to be approved by exchanges so that they can write insurance under the exchanges. Some of my graphics went away for some reason. Oh, okay. Thank you. No, I'm teasing him a little bit. He's better with the technology than I am. In terms of how an exchange operates, an individual decides to apply. In the first step, they say, what benefits do I want? How much do I want to spend? And what's available to me in terms of MDs and hospitals. There are a number of plan choices that present themselves. There's a gold, a silver, a platinum level of plan, and they will all be defined. It's a little complex there, but basically it has to do with how much of a copay or deductible comes with the plan. Someone who has a little more income might want to buy a little higher, a little lower deductible, a little lower copay feature. In terms of Vince here going through the process, he selects a plan, completes an online enrollment as one of the options. There'll be a paper process too, a facilitated process, but you can do it online. And in Massachusetts, the connector experience there, where they've been operating the exchange now for 4 years, is that most people do use the online process. And organizations like TRC might help their membership go through that process. Picks a PCP and pays its premium. The premium's collected, and then the insurance company who's written that plan sends Vince his enrollment information, his card, and then and they're prepared to play plans at that point. So that's just a quick operational procedure. 4 quick issues in the design of exchanges. There's the carrier bidding and selection process, so that we manage competition, transparency, and hopefully long-term relationships with the insurers who try to get into this process. There'll have to be good benefit specifications, so the essential health benefits are the key standard by which these plans will create benefits and qualified plans. They'll have to be standardized for easy comparison, change process from year to year will have to be very transparent, very consumer friendly. Again, understandable benefits. What is the common question when you get a health insurance policy? This is an effort to make sure that's simplified. And finally, there's a number of administrative functions they have to carry out. On the essential health benefits, terribly important part of the Affordable Care Act, the bulletin we've printed for you. You can go to that. It's the first time HHS has issued a bulletin that's not its typical communication process. Usually it writes regulations. In a very unusual move, they issued a bulletin by which to do this. Don't exactly know what all the reasons for that were, but it is basically it's a regulatory framework. There are 10 covered services. They're listed here. They include chronic condition management, habilitation and rehabilitation services, lab preventive, a lot of services now that haven't been considered essential in the design of a health benefit. So again, another opportunity and very important to shape. Keep your eyes on, work through your advocacy functions to make sure that they include the things that are appropriate for your population. The scope of the essential health benefit, it has to be under the law. This is the legal reference. It has to be provided as a typical employer plan. And among those 10 categories that are inpatient, outpatient, maternity, emergency, etc., there has to be a categories. So you can't have all your benefits in inpatient or outpatient or just for laboratory services. And then again, as we noted, this will cover the individual and small group market plans, the Medicaid benchmark plans, and just basic health programs as well. I'm not going to go into this because it's a little lengthy to do much of an explanation for. I will say that the Institute of Medicine, HHS, contracted with IOM to develop what should be essential health benefits. And they came back with a very interesting recommendation, and being a little concerned about why it might have, that they came back with a small health plan benefit definition, so that's a lesser benefit. A small health plan benefit typically today among insurance plans provides a range of services, but they're more limited. And the law actually called for something broader, and HHS went ahead and didn't go with the IOM recommendations and provided benefit that I think is much, an interpretation of the 10 essential benefits is much broader. And of course, this is terribly important because it impacts some 70 million Americans. If you want to do the whole health,
sure.
This was a very important advocacy effort to say what should be in the benefits.
Right, right. You know, and one of the things I'll say too about, before I leave the topic, is as you were talking about the health insurance exchange, in one of Bill's earlier slides, there was a range of income on an individual and family basis. And for the health, and of course, Medicaid expansion is up to 133% of federal poverty level. The exchange picks up from 133 to 400%, and they're in that range will be a sliding scale of eligibility for subsidies or vouchers to buy those plans. And it's one of the things that I think is important to mention, because somebody might be working, doesn't necessarily mean they can afford the whole premium, and the exchange will be able to buy that insurance, get a subsidy from the government to buy the premium, and they'll pay a portion based on where they fall in that range, and so it's quite a benefit. With respect to the essential health benefits, the Campaign for Whole Health is a cluster, it's a group, an alliance of various behavioral health care and social service advocacy organizations around the country that came together to delineate what they believe, and by extension what we all believe to be the essential mental health and substance use disorders benefits. And I think that they're important for us to understand, because they're what we need to be advocating for in our own communities and with our own legislators and with their health committees and in Albany and so forth. And to your association, you need to be able to advocate for these things. So they've identified rehabilitative and habilitative services, and those are described here. They've identified recovery supports, community-based recovery support services, and peer-provided recovery support services, all of those things that are wrap-around social supports that are so important to the effective treatment of mental health and substance use disorders. So that information is there. This is the kind of information, frankly, that I think we need to be bringing to our legislators and to the decision and policymakers. They're also recommending preventive wellness service and chronic disease management in a way that's real consistent with what's in the ACA, or the Affordable Care Act. The Affordable Care Act actually goes, I think, in a bold direction and says depression and alcohol screening must be covered benefits the same way immunization is covered. They're services that have to be paid for first dollar. So the depression screening and alcohol use screening, somebody can go in and with no copay, no deductible, that screening is provided. And smoking cessation services for adults as well. So I think these are the kinds of things that are real bold steps that the Affordable Care Act takes in our direction and recognizes the importance of these things. Okay? There are some obstacles, I think, that as essential health benefits get defined at the state level, even though the guidance is coming from the federal government, it's going to be decided it's a state's issue. that we have decision makers who aren't real savvy when it comes to behavioral health and social services. So if we leave it to them, if we entrust it to them without informing them and educating them, they could make the wrong call. So that's why Bill and I are going to reinforce this. Take this message, take your ideas about what you think constitutes essential health benefits, and take that to your legislators, take it to the governor's office, wherever you need to take it to advocate. The other is that the insurance commissioner, to the extent that any state's insurance commissioner is responsible for the oversight of health insurance plans, including the exchange, okay, they don't understand our field. They very seldom have a full grip on what it is that we deal with day in and day out. We have a lot of state agencies that don't talk to one another. So if we think, well, don't worry, you know, Family and Children's Services will talk to Medicaid and Department of Corrections will talk to the insurance commissioner, they don't know each other, let alone talk to each other. So we need to help them overcome that chasm. I think that in many instances, the planning and the development around healthcare reform is very sort of medical model. It's large, big infrastructure, and it's real easy to forget, you know, the behavioral health and social service fields. And actually, that brings us to the Mental Health Parity and Addiction Equity Act. You may be wondering what that weird acronym that's no one can pronounce, but they try at the federal level. They call it MAPIA. But in 2008, the Mental Health Parity and Addiction Equity Act was signed into law by then President Bush, which provides a fantastic coverage for mental health and substance abuse services. Problem is, it hasn't been fully implemented in very many instances, and there's a definitional issue here, and that is it goes to what's called scope of services. And that is what diagnoses are covered, what providers are covered, and what services are covered. Essential health benefits, when they get defined at the state of New York level, will be magnified by Mental Health Parity and Addiction Equity Act. So whatever is poorly defined in either one of those is going to aggravate the definitional problem. And that's why I think if there's an implication here for you guys, if there's something for you to do, is to think about what should be those covered services, who should be the covered providers, what should be the covered diagnoses, and what is it in the essential health benefits then that we can dovetail that with. And that's the message that needs to be brought to Albany. It must be. Because if you're not part of that, then you're going to feel like at the end of the day when they do come out, my gosh, we missed our opportunity. Okay? Number of different payment models. I don't know if I may as well just keep going because we're getting close on time. You know, we talk about an evolution. This really is an evolution from the Great Society, when for the first time we started to think in terms of large social programs, to the block grant era, Ronald Reagan's mental health and substance use disorder block grants, and now to what for all intents and purposes can be universal coverage. So we've come a long way, and one of the things we talked about in the car on the way over here last night is we've come a long way since the days of deinstitutionalization. And you think about the tradition of deinstitutionalization and moving services to the community and ensuring some dignity and some respect. And now I think with the addition of integration and really making sure that there aren't any cracks for people to fall through, that's really the nature of the evolution. I'm going to go ahead and pass through this here, and I'm going to pass through this. I'm going to go right to reimbursement reforms because I think that they're beginning to have an impact. We're starting to see opportunities. We're starting to see proposals for new forms of reimbursement that will be different from block grant, which is, you know, the era again of Ronald Reagan's mental health and substance abuse block grants. And it's different from the fee-for-service kinds of payment methodologies we've been used to, and in some cases, some people are just sort of gearing up for billing and fee-for-service. And while it's not going away, that's my humble opinion, we are going to see, I think, with accountable care, with health homes, with patient-centered medical home models, the idea that there be some full risk, some partial risk, some form of capitation, and that capitation, for those of you who aren't, you know, insurance folk, is a way of saying, here's the premium, and here's all the care that you need to provide this individual in this span of time, and we're going to give you a portion of the premium to provide that portion of the care. And the capitation is you get paid on a per cap per month, per head per month. Okay? And that was something that began in the 80s and proliferated in the 90s under managed care and HMOs. But again, the incentives were all sort of, you know, people call them perverse incentives back then. You got to keep more of your cap rate, more of your capitated premium. You kept more by virtue of the care you didn't provide. So now we're going to see, I think, some reimbursement reforms like global payment that say, you know, you've got to provide a global array of services, and then you'll get to keep the incentive, you'll get to keep any profits only if and when you produce a better outcome. And that goes to value-based purchasing and performance-based purchasing. The idea that if we create outcomes, if we have higher quality, if we have better safety, if we have fewer readmissions, then we will have produced value. You're going to hear that term, value. You're going to hear value-based insurance design, value-based purchasing a lot, because we can't keep doing what we were doing in the past, which was paying fee-for-service for whatever anyone wanted. And that's what led to the runaway costs. So global payments, performance-based contracting, and these other models are about reining in the spending in that fashion. We could talk for a long time about capitation. I'm going to have to squeeze through it. And case and episode rates, I will pause on just to say one of the reimbursement reforms that's on the table is not the idea of saying we're going to send you a patient and then you bill us for each and every service you provide, but instead looking at the patient as a case over the next 12 months, what are their needs, and we'll pay you for all of their needs. And if they go over, they go over and you eat it. If they go under, then you get to keep a few bucks at the end. But at the end of the day, you will have had to provide what they needed. And we're going to look to the outcomes and patient satisfaction to make sure that you did your job. Okay? Global reimbursement, we could, again, I think we've touched on it enough. I think the implications here, I will pause long enough to say, for those of you with a finance hobby, or for those of you in a finance role, for those of you who are involved in billing, for those of you who are involved in providing services that get billed, so basically all of you, all right, are involved here, there's some reading to do. If nothing else, read this stuff, and the questions are all good. Capture, harvest all of those questions, where it says here that there's an incentive for outcomes, and well, what does that mean? What kinds of outcomes are we measuring? And are they the right outcomes? Should we be maybe collecting some different, why are we still collecting it on paper when we could be doing it with a kiosk? Why don't we put a computer in the lobby? Those kinds of things, bring those questions, I think, to the surface, because your success in this area and with reimbursement reforms will depend on your ingenuity. This is a time where the entrepreneurs and the ingenuity is going to be the cream that rises to the surface. It's an opportunity, and the faster you rise to the surface, the better. Okay? So lots of information here. I will pause here long enough to say, when we're talking outcomes, there are a lot of people in the grant and aid and categorical funding mix that have been habituated and acculturated to outcomes based on the category of funding that they get. So if you're a substance use disorders provider and you're used to, you know, the block grant, the TEDS data, and NOMS, the National Outcome Measures, back to the federal government, well, that's one set of indicators. In the managed care, there are HEDIS, or Health Effectiveness Data and Information Set. There's the National Quality Forum. So there are going to be a number of different indicators that are pointing to different aspects of whether it's quality of life, behavior, symptom, functioning. All of these things are going to need some study. So if you have some interest in outcomes measures, now's the time to start to do some of that. Some of these models, I think, for those of you who are making some financial decisions or have some input to these financial decisions, we've set up the sort of pros and cons of financial risk. Okay? So risk is one of those words you're going to have to get used to, because as we hybridize, as we take providers and graft them onto payers, and you start to look a little bit like both, you have to understand the risks inherent with that. There are some advantages, for example, to performance incentives. They tend to be upside, not a lot of penalties. There are some disadvantages, particularly if you've got that portion that would be your incentive withheld. That can hurt at the end of the year. If your outcome measures are poor, you don't get that withhold back. Okay? Shared savings, I think there are some advantages there, particularly for those ACOs that are approaching the upside for the first 3 years. One of the routes you can go with CMS is to say, for the first 3 years we want no downside, just upside. And but again, any kinds of withholds will be a problem. Administrative fees, if you're going to vie to become a navigator, under the CMS definition of a navigator for a special needs population, you might get paid an administrative fee to provide that function. Very little downside if you know how to cost your services and you can stay efficient. That it can be very good for you. Case rates and episode rates we just talked about, I think they're fantastic. I think it's a great way to reimburse people for services. The problem is, boy, if you don't understand the pent-up demand and you agree to a rate, and it's $10,000 per case, and if you haven't done your math properly, you haven't understood the pent-up demand, you haven't understood what happened in the past and looked at good, solid, reliable data, you can take a beating the next year when people use more services than you planned for. The same with global payment, and I think with capitation, there's plenty there. So some of the other steps, some of the other implications, aside from reading this stuff and harvesting your questions and talking to one another, is you now need to start to think in terms of health insurance. Because the days where X% of your population were uninsured are coming to an end. They're either going to be insured through the exchange, or they're going to be insured by way of Medicaid expansion, or is it dual eligible, dually insured. And a very small fraction of the population, you talk about Massachusetts, about 3% on insurance in Massachusetts. So we're all going to be called on to become at least conversant, if not fluent in health insurance speak, and in managed care speak, because those concepts are going to be our day-to-day reality. Okay? Negotiation of contracts, which is something that we're working with some of you on right now, is another area where we're going to have to expand our domain and our subject matter expertise and come to know things a little bit better. And I think to the extent that we think about how social supports, how vocational training, education, mental health, substance use disorder services fit in a medical context to create what I really like the term behavioral medicine. That's the direction we're going in. You can resist it if you want. Good luck with that. But I think the era of integration is the era of integration. We will integrate. That doesn't mean we will assimilate. All right? So it's integration, not assimilation. And that's, I think, our charge. We've got to get good at preserving the very best of what we do. But we have to do it in a way where we're also accepting of integration. Okay? Parity and equity. Bill, do you want to take this home?
Yeah.
All right.
I want to take this home in 1 minute. Because I think it's time for, if we're going to have some, do we have time for any audience? Or we?
No, we'll just move those tomorrow to the archive.
All right. Okay. So I guess just in terms of Parity and Equity Act, basically what I'd say about it is it's a significant step that was taken in 2008. There have been parity acts passed by Congress before and enacted into law, but they've never really taken effect. And what it really was meant to cover is the group health and employer health plans more than anything else, because that's where the greatest amount of discrimination took place. So if you had access, if your employer was buying you a benefit package and you had mental health benefits in that package, they would be different than the health benefits you had. Under parity, they now have to be structured the same. There are many ways. We have some slides in your packet that goes into non-quantitative treatment limitations and other terms that are part of insurance speak. And I don't want to address those. I just want to make a big point that it is a significant step. It has to be, well, it's law, and group health plans now have to do a lot more. And those of you who have to deal with insurers as part of your jobs know how much easier it is, or should be, today to work with people who have a group health coverage as a result. And it's part of making behavioral health benefits more universal, combined as a named mental health and substance use benefits and the other named 10 essential health benefits, particularly mental health and substance abuse, are now covered under parity, and so they are part of our future. We just have to be vigilant about it and not let it go beyond that. So, concluding slide, I'm going to let you do this, Patrick.
Oh yeah. Good. This will just, I want to provide this and just give a brief explanation before we break. And that is, we go around the country, like I said, we do a lot of this, so we're talking about all of these different moving parts as though they're somehow disparate and disconnected. And they're not. In fact, they align quite nicely. And I've always given the analogy or the metaphor that it's a kaleidoscope. And if you look through the one end, the very first thing at the top of that kaleidoscope is expanded coverage. We're giving 32 million people access to coverage they didn't have before. Then beneath that, for our purposes, are two things that are critically important: essential health benefits and the Mental Health Parity and Addiction Equity Act. Those two things go hand in glove, and they determine the kinds of coverage and services that our folks are going to have. That becomes our reality. That becomes the business rules that we have to live by. Then there's a business structure beneath that, which is the ACO, okay, and the CCO, in some cases, coordinated care organizations. Oregon has one, Illinois is developing that for Medicaid. But there's a business structure. And that's important because we all work for a business. And I don't care if you're a not-for-profit or for government or a for-profit freestanding hospital. We all work for a business entity of one stripe or another. And this is a market structure change. And I know that some of you have been looking closely at ACOs and you go, wow, this is different. It's a new business structure. There's a lens underneath that then that says, well, what's the clinical model? I've got an interest that's purely clinical. What kind of a clinical relationship am I going to be in? And that's where the patient-centered medical home and the health home model happen. That's where that lens occurs. Underneath that, you've got to have an infrastructure to support the communication, the collaboration, right? And that's where EHRs, electronic health record systems, and health information technology become prominent. That's the underlying infrastructure that enables all of this other stuff. In other words, you can't do an ACO if you can't share health information. So you can bump up a level to that business structure and you may as well take it off the screen. You have to have the underlying infrastructure to participate. And then underneath that is and it's not the final, but it's just another lens to consider, is the workforce. Now, what are the workforce implications for each of us? What do we need to learn? What kinds of continuing education opportunities do we need to provide? If we're managers and supervisors, what do we need to do to set an example and to mentor the people who work for us? And are we a learning organization? And I'll leave it at that. I think because we're in a new era, this integration age, we have to become learning organizations. And that's not something that Paul does. That's something that everybody does, that we become prolific learners. And it's the people who learn and who accelerate their pace of learning right now and start to innovate and think critically and think creatively and think about new relationships between old parts. They're the winners. They really will be the winners. Okay, so become a learning organization, and that's it. I'm going to stop talking.
We'll leave you guys hanging for questions and more dialogue tomorrow when we get together in our small group sessions. But we really look forward to the continued work that we're doing on healthcare reform and figuring out how we're going to navigate through the storm that we're in the middle of right now. So why doesn't everybody take a quick, probably 10-minute break and then come back and we'll be ready to get started again. So thank you.